Good to be live now, Elizabeth. Just a nod. Are we there? Okay, morning everyone, and welcome to this BAPRAS Advanced Educational course on the breast and lymphedema. My name is Dean Boyce. I'm currently BAPRAS Education Chair. You'll probably know that this course was originally planned for a face-to-face meeting last April, but clearly we had to postpone that because of the terrible virus. So the format of the course has clearly changed, but we've tried to maintain the general structure with plenary lectures and also interactive elements with breakout session and MDTs. When we get to the breakout sessions, you've already been allocated which session to attend first, and then simply move on to the next as the session, as the program progresses. Please keep your cameras on during the sessions, as it's meant to be an interactive session. So that you can interact with the session chairs. It's meant to be a two-way process. You can also ask questions during the lecture sessions via the live Q&A button at the bottom. We can then answer the questions and discuss them during the discussion sessions. After lecture or session, you need to press the link to go back to the timeline in order to then click on the next lecture or session. There's also a virtual exhibition room, which I encourage you to learn about new products from our partners in industry, and a room which will give you the opportunity to interact with other delegates. Occasionally myself or Joe will pop up on your screen if the system works to direct you. Please bear with us. This is only the second time we've held a course in this format, and this is a new platform for even events there, so it's a bit of a learning process for us all. So I hope you enjoy the course and learn lots, and I'll hand you over now to Joe Skillman, who's done a huge amount of work in convening the original course and then reformatting it to its current format. And Joe's going to tell you now a little bit more about the content of the next 3 days.
So welcome everybody. I'd first like to thank you all for attending and coming to this virtual meeting. I know there's a lot available, and I hope that this one will be very useful and informative. And I'm really grateful to the faculty for giving up their time both to prepare the lectures and being here on the day. Can I ask, pass on a request from the faculty not to use the photographs or record the lectures and let the photographs leave this forum. So the patients have agreed for teaching, but not for them to their photographs to be more widely disseminated. The lecture part of the course is the first session of the day, where faculty have pre-recorded lectures for you to view, and those lectures will be recorded and will be available for 3 months. You'll be able to access them about a week after the course has concluded via the original link that was sent to you as a link to the course, so you can watch those at your leisure. The breakout sessions are more interactive and are not going to be recorded, and therefore won't be accessible after the course. If you have any issues with your IT, at the top right of your screen, there's a live support button which you can click to access help and support with accessing the talks. The first day today is based around aesthetic breast surgery and challenges in aesthetic breast surgery. So we've got some fantastic talks which should be a great setup for planning and delivering aesthetic breast surgery. And then we have some interactive sessions about more challenging problems in aesthetic surgery. And finally, after the tea break in the afternoon, an MDT where we've collected some challenging cases which should bring the whole day together. I hope to keep to time as much as possible. The first session, Mr. Nigel Mercer is kindly going to speak to us about his experience and aesthetic surgery, and I'd like to hand over to him now. We will have a question and answer session with him immediately after his session, but the remaining Q&As will be at the end of the final session before the tea break. Dean, is there anything else you'd like to say before we move on to the recorded lectures?
That's perfect, Joe.
Okay, so Elizabeth, would you mind starting the first lecture, please?
My name is Nigel Mercer. I'm a consultant plastic surgeon and I'm the lead evaluator for the certification scheme for the Intercollegiate Board in Cosmetic Surgery. And I've been asked to talk to you about the accreditation in aesthetic surgery. Now, that's not a brilliant title because we are accredited in our own specialties. And at the moment, there is no accreditation in aesthetic surgery per se because it is not an established specialty in its own right. So my aim is to discuss the history of regulation in the United Kingdom, what regulation is now in place, and what we hopefully will all comply with. So what are the factors in the regulatory equation? Well, first of all, we have the patient, we have societal norms, the law of the land, and we have us, the surgeons. As you can see, this is from the British Medical Journal some time ago, are surgeons psychopaths? So if we look at the history of the problem, whose fault is the unregulated cosmetic industry? And it's often said it's social media, the selfie culture, Zoom neck, profit before patient clinics and clinicians, commoditisation by media and profession, too gullible, too trusting patients have been criticised as well in the past. That is completely and utterly unjust. No specialty of cosmetic surgery medicine, as I alluded to. There has been playground politics over that, both with the government and within the profession, because the cosmetic world is viewed as murky and slightly below the counter, should we say, particularly up to the 1970s, 1980s. But it's now very mainstream, and the medical profession was left a long way behind. Perhaps one of the biggest issues in the United Kingdom is that we have the TK Maxx mentality, and I love going to TK Maxx. It's like, you know, like my equivalent of a jumble sale from when I was a child, but the clothes are all new, and we all love finding a bargain. The problem is that the way the cosmetic industry, and we have to call it an industry, has been put forwards now is really much as if you can buy something at bargain price and still get a Rolls Royce or get a designer effect, and that we all know is not the case. The media have to some extent been part of the problem. You know, Love Island has shown Love Island, if you like, excuse me, lips and tits. If you look at the images, a lot of them will have been enhanced in some way. And we also know that in the print media, images are enhanced, as has been shown by these images taken from the internet. So what about the playground politics? Well, there's perceived lack of regulation, particularly by the government, GMC, General Dental Council, etc. The CQC, Fin, Department of Health are not viewed as being great regulators. The professional associations have not really got their acts plural together. The malpractice insurers, until recently, have been slow at singling out poor practice and making people with poor claims histories pay more. But that is now much improved over the last 10 years. And the finger has been pointed at both the MHRA and the European Union for their role as regulators over some of the healthcare products that we use. Hopefully, now that we've left the European Union, we will have the ability to change our regulatory framework in the bills coming through Parliament, and actually to make the situation much safer for our own patients. But actually, the biggest problem is it is a complete free-for-all for the businesses. The businesses can behave like any business, and we've seen that on several occasions within healthcare, where perfectly viable businesses have been put into receivership overnight, had all their funds moved abroad to a tax haven, and are then opened up the following day under the same trading company but a different holding company, leaving patients with absolutely no legal cover. So where do we start? Well, 2008, really, BAPRAS started with the Be Sure, Be Safe plan, and then out came the 6-point plan, and you can read through that, and that's still out there, and is still extremely relevant. But then, unfortunately, in 2010, Denise Hendry, whom I'm afraid I never met, died just over a year, having had liposuction at a private clinic in the northwest. And she suffered multiple perforations of her bowel in the process, and was taken out through the back door of the clinic, past the bins, to the waiting ambulance, so that it didn't upset or worry any of the patients who were in the waiting to go in to have the same procedure done. The surgeon left the United Kingdom and voluntarily erased themselves from the General Medical Council register, and therefore no action was taken against them. And because Denise Henry died more than a year after her operation, there was no criminal charge about that. The family set up this foundation, and I met Colin Hendry, the famous football player, at that, and their children. The government looked at this and issued Let's Face It, and you can see exactly what they were calling for within the Let's Face It report, and it was completely ignored by the government. We then moved on. 2014, 2017, the European Union became involved, and the Austrian Plastic Surgery Society sponsored setting up a European standard in aesthetic surgery services, and this was published in 2014, and the cosmetic service specification and standard was published in 2017, and these are still available, and they would need to be revised in the near future because they are supposed to be revised on a regular basis. But effectively they applied across 31 members who members of SEN, and also 19 affiliate other countries. So their effect could be pretty widespread, but unfortunately they had to be bought from the British Standards Institute in the United Kingdom, or the Irish Standards Institute in Ireland, and they've not been well taken up, but a patient could use these in a court of law if need be. We also have the delivery gap, so the patient expectation of having spent no money and receiving a Rolls Royce is effectively translated in our working life into over-promising a result, and the patient expecting what we can do, and then feeling that they've been under-provided. They've thought they were buying a Ferrari, in fact they bought a Fiat 500. So what regulation do we have at the moment? Well, we have Good Medical Practice, which was updated in 2019, and this is a document that you must read and you must adhere to. If you don't, you will fall foul of both the General Medical Council and almost certainly of the law if you're found wanting by the GMC. We then went on to the Kia review, which is post the PIP scandal, and the Kia review really strongly recommended better regulation of the cosmetic industry. And the first committee was set up by the Royal College of Surgeons of England to start to look at that. So the Kia review reported in 2014. We then went on, and the professional standards in cosmetic surgery were produced by that committee, and that has now become intercollegiate and has been revised within the last year, and is now supported by all 4 colleges in the British Isles. And out of that has come the introduction to the Cosmetic Surgery Certification Scheme. The first iteration of the scheme was not well taken up for a variety of reasons, and the new scheme is now supported by the professional associations and by all 4 colleges, and there is a good website which has been relaunched explaining how to go about becoming certificated. Now, the GMC will be taking certification over as one of their credentials. Cosmetic surgery is the only surgical credential which the GMC are considering at the moment, but they are having some difficulty about this because it's difficult for them to match it to the existing curricula which they have for other specialties. But that's work which is ongoing. And as you can see at the bottom, the website for the certification scheme is set out. So particularly for the cosmetic breast surgery certificate, what do you have to do? Well, you have to be on the GMC specialist register or registered with the Irish Medical Council. Now, since 2002, the Care Standards Act, to perform cosmetic surgery, you've had to be on the GMC specialist register. Now, you could, in theory, be on it for orthopedics or for vascular surgery or for any of the other 10 specialties which are legally defined, and still be able to perform cosmetic surgery. The certification scheme is aimed to try and avoid that, because as you can see, to do cosmetic breast surgery, You have to be trained in general surgery with a declared special interest in breast surgery, or trained in plastic surgery. You can no longer be a vascular surgeon or an orthopaedic surgeon, as is reported currently working within London performing breast surgery. That will be outlawed by this. The same applies to the other areas of cosmetic surgical specialisation. There will be defined specialties that can perform those procedures as well. So it doesn't allow for a general practitioner or every other Tom, Dick and Harry, and indeed Harriet, to get involved in the work. So the application form is done online. You have to give evidence of professional indemnity insurance. Now that will vary depending on which jurisdiction you're in, but essentially that has to be checked to make sure that you do declare the fact you do cosmetic surgery, in this case cosmetic breast surgery, and that the quantum that you're paying appears commensurate with the amount of risk and the level of cover which you carry. And if there are issues about that, then the team who administer the scheme will ask for more clarification about the level of insurance you cover. And the thing to remember about insurance is if you're underinsured, you are not insured. And since this is done on a yearly basis, and usually a year in arrears, if you earn more in a year than you paid indemnity insurance for, you must tell your insurance company. So if you have a claim in that year, they may come back to you and say, sorry, but like your house insurance, you are underinsured, and therefore in this situation, you are not fully insured for any claim. It's standard practice in the insurance industry. We all understand that with our general insurance. Medical indemnity insurance is no different from general insurance, and you must make sure you're fully insured. We ask you to attend the online course about professional behaviours. That's terribly important. And for those who are registered with the General Medical Council, evidence and revalidation, including the 360. The 360 can be illuminating because some surgeons will rate themselves below how they're rated by their peers and by their patients. Others, and quite a surprising number, will rate themselves as if they can walk on water. And it's those individuals where we would wish to see some element of that being reflected on in both directions, both rating below and rating above. That should be reflected upon in the annual appraisal that follows the 360 being performed. We have seen significant issues with people like Patterson, who clearly felt that they were above everybody else in terms of their actions. And it's important that we are certain that people are reflecting very, very well and deeply on the work they're doing. We ask the operative numbers and we ask the clinical outcomes, and you can see the data that's reflected there, and also the fact you're doing CPD in the subject which you wish to be certificated for. And the reflection on practice, as I've said, is absolutely fundamental. If the reflection is not good on the cases which you supply, we will come back to you and we will ask some more questions about that. Because one of the most important things for anyone working in cosmetic surgery in particular is to be able to reflect on your practice, and particularly on your complications and difficult cases. And we also ask for two references. The operative numbers collected within 6 years. They can be extended on a pro rata basis for part-time training, and essentially, if you're not on part-time training, can be extended out to 8 years on a case-by-case basis. So it means that pretty much every trainee or young consultant should be able to reach the numbers without too much trouble. Those who've been in practice for longer, whose practice spectrum may have shrunk somewhat, may have difficulty in accrediting in some of the wider based fields, but they should still have no troubles for the areas in which they are expert. You can see the numbers of credits that you can accrue, and that 50% of the credit allowance stated here is applied for crossover skills in reconstructive cases, and that goes across all the areas of specialisation. So, the certificates also state the area that you can practice in independently, and you can see those written here. It does not allow you to do other things which are not included there. And so it's very important that we are aware of the spectrum of work in which we're certificated, and that we make sure that we are expert within it. So cosmetic breast surgery requires 40 credits, which at least 8 must come from the 3 areas of augmentation mammoplasty, reduction mammoplasty, and mastopexy. So that's 8 from each of those 3, which is 24 credits. So 16 credits can be gained in other areas: breast symmetrization, gynecomastia, and cosmetic surgery in the nipple areola complex. And the crossover skills for breast surgery would be implant-based reconstruction. And as you can see, de facto means that 16 cases would need to been performed as main operator to gain those 8 credits on the 50% basis. You should also have seen patients in dedicated cosmetic outpatient consultations, because they are different in subtle ways from those in which you take part in NHS practice or within government practice in Ireland. And it's very important that patients do have fully informed consent for this type of surgery, and all the risks and all the alternatives which are available to them. So reflection on practice: basically there are 3 options. Majority of people have been submitting 4 complex written cases and reflecting upon those, and it is illuminating to see what people have put in and the amount of reflection. If the reflection is not good, I'm a responsible officer in another part of my life, we will go back via the secretariat of the scheme to ask for better reflection of the cases that have been supplied, just the same as your appraiser would do in your revalidation. We have to remember that we are all completely bound by Montgomery, dating from 2015. Patients have got to be fully informed of the risks that they see material, not that we see material. So, for example, BIALCL would be a material risk to anybody. It's a form of cancer, and you should be warning people that they are at risk of developing it, although that risk is uncommon. So, very important that patients are fully informed, and the consent process is completely documented in your notes. So incredibly important that you do not lose sight of that, because if you do, you will end up in trouble both with the GMC and with the law. One of the things which I think the profession feels very strongly about in all areas is that we have moved too far towards cosmetic surgery becoming a commodity rather than a professional service. And one of the interesting things about the Montgomery ruling was, in the last page or so of it, it turns around and talks about the patient being a consumer of healthcare. Now, that was done for a particular reason, but it may also have the effect that it brings in consumer legislation into provision of healthcare, which is going to be extremely difficult, particularly in cosmetic surgery. So we have to be very careful about our marketing and self-promotion. We have to be certain, and certainly the knowledge, that an unsatisfactory product leads to replacement or refund, and the patient population having cosmetic surgery definitely feel that. They think it's like buying a perfect product every time, and that there are no risks associated with it. And ladies and gentlemen, I'm afraid we are partly at fault, because we've not got the message over that surgery carries an inherent risk, and it cannot be guaranteed, nor can the result. So the certification scheme is the principal way for the profession to improve patient safety. It's not there to restrict your practice. It is there to improve patient safety. That's its fundamental ethos. I think all of us who perform cosmetic surgery would wish our patients to be dealt with in the safest possible way and safest possible environment. And if that's not your ethos, then you should probably not be entering into cosmetic surgery. The certification will align with revalidation in the United Kingdom, and the transition to the GMC will be one which is ongoing over the next few years or so. The profession very strongly feels that it would be better if this were mandatory. Unfortunately, at the moment, it is not mandatory, but we are very much hoping that the hospital groups in particular take on the mantra that it is important for all their surgeons performing cosmetic surgery to be certificated, because in that way they can then have some way of assuring patients that they are in safe hands. If you do have any questions, I look forward to answering them in the Q&A session. Thank you.
Thanks, Nigel. That was really insightful as usual. Can I just remind the audience that you can ask questions via the Q&A. I can't see any yet that have come up, but please do ask questions. Nigel, am I right in thinking that the credits that you describe are accumulated over 6 years?
There's one thing which I wasn't able to put in because it wasn't in fact agreed, and it's still not quite agreed. We are hoping that there's going to be something called the established practitioners route. People who've been in practice for some time. It was quite a hurdle to have to go through to go back and accumulate the numbers over a 6 to 8 year period, depending on what you've been in part-time training. So we are hoping to agree in the next few days an established practitioner route, so that if you have been in practice for 2 years in cosmetic practice, the system will be slightly different, but that will only be open for a short period of time, Dean. But at the moment, it is effectively 6 to 8 years. So people coming off of training will hopefully, in breast surgery, will hopefully have most of the credits they need to be able to apply. Will be effectively parallel to the established practitioners route, but that, as I said, is not yet quite agreed.
Okay, so basically, if you've got a qualification in breast surgery or in plastic surgery, as long as you accumulate those credits, then you're accredited to be a cosmetic specialist in that area.
If you've been in private practice for 2 years and you...
Sorry. Very, very famous, my dog.
You will still need to prove the numbers, so it won't be an automatic process. There'll be some form of audit process around the numbers, but yes, it will be a similar. Sorry, don't know where that came from. So it's essentially that you can do the job. I've lost the sound. Sorry, Dean, I lost you there.
Can you hear me now?
Yeah.
There's a question on the Q&A of whether experience gained abroad can be used for certification.
If it's in your logbook, then that would. So yeah, I mean, basically, it's a personally verified basis from that point of view. So experience is experience.
Okay, thanks, Joe. Over to you.
Sorry.
Okay. There's another question which says, do the requirements line up with the JCST curriculum requirements for plastic surgery? Is there any alignment with that?
Essentially it is aligned. Obviously, for your CCT, this is a post CCT qualification. So the idea is that you'll have to have been in ideally for 2 years. If you come off the top of CCT and you have the numbers that for the criteria, then yes, you can get your certificate. But if you haven't, then you have time to then accumulate those. So each individual application is done on its own merits. Each application is viewed by 2 evaluators, specialty, They have to declare any interest if they have any problems about viewing that. If there are any there are passed up to the lead evaluator to have a look.
Great. Okay. Just one question for me. I've been of a plastic surgeon who was creating a calendar of his post-operative patients. Is there any regulation on advertising and the standard of advertising cosmetic surgery?
Well, this was covered extensively in KEO. We had some long discussions with the Code of Advertising Practice and the ASA, who felt that it's a product, you should be able to advertise it. It has to be legal, decent, honest, truthful, and socially responsible. Issues. Women who are seeking particularly breast augmentation are a vulnerable group. They've got a higher risk of suicide. That's well proven now in the literature. We know the issues about BALCL, and if there's any promotion or encouragement of women to go into having an operation, then I think that might be deemed as socially responsible. Everyone's got to be incredibly careful about the line that they tread with their own marketing. Really, really important.
Joe, how's your feedback?
I think it's better now. Can you hear me?
Yeah, perfect.
Thanks so much. It was a really fantastically clear talk, because there's been a lot of rumours about, what will everybody have to do and things like that. Would you recommend that people apply now, or once it has moved over to the GMC? And do you have a timeline of when the process will have moved to the GMC?
We still don't have a timeline of when it will be over with the GMC. Getting it aligned with the GMC is an interesting issue, because what we're trying to do is to limit who can do cosmetic surgery to people who are properly trained, and essentially to consultants. The GMC, there will be an issue about SAS doctors, and there is a lot of discussion to go on still about who can do what in the private sector. Certainly apply now. So 2 weeks or so, there's still some discussion to go on that, but hopefully that will be available, and particularly for people who are more established and have done 2 years in private practice, then maybe waiting until that's available. It'd just be a simpler process for you to go through, rather than doing the filling in the forms as they are for the straight through route. You can do either. It's not a problem.
When do you think, for those people who've been in established practice, when do you think the other system will be available, where you can sort of fast track on the basis of your experience?
Well, so long as it's signed off, it would probably not take terribly long to get it up and running, but I would think it would, in reality, it may be by the autumn, something like that.
Okay, that's really helpful. Thank you.
Time on that.
Thanks so much. Okay, so I think if you're in agreement, Dean, we'll move on to the next recorded talk. We're going to do Q&A at the end of all the recorded talks. So please feel free to add them to the live Q&A box, because then they'll be recorded and we can go through them at the end. So Elizabeth, would you be able to put on the next talk, please? Thank you very much, Mr. Mercer.
Hello, I'm to talk about really breast health before cosmetic breast surgery. I am a breast surgeon with a significant experience in both reconstructive and aesthetic surgery, and I have no conflicts of interest, but would recommend to those who wish to desire to learn a bit more about these two areas towards the University of East Anglia courses. What I want from this presentation is for you to think about the individual in relation to their current and future breast health. And to do this by knowing what questions to ask, what you need to know, what to look out for, what is actually normal and what may not be, and what you may be asked as well. Always remember there are fundamental differences between reconstructive and cosmetic surgery. Firstly, in respect to the goals of the patient and the surgeon. But sometimes the hardest thing to remember is that realizing that cosmetic surgery is not essential or needed. You can say no, you can refuse. And the more experienced you become in cosmetic surgery, the more you realize the importance it's knowing when not to operate, rather than how to do it. And when things go wrong, they can go hideously wrong. This is a woman who was a diabetic who had a revisional augmentation mastopexy, and you can see a visible implant just. And this is another augmentation mastopexy in a heavy smoker. These are complications that could have been avoided. I would recommend looking through the 2016 Royal College of Surgeons publication on professional standards for cosmetic surgery, which identifies the obvious importance of assessing the whole patient and understanding their comorbidities, general health, and medication. Psychological health of your patient is extremely important, and specifically in cosmetic surgery. But I will not cover this today. It's not really breast health, and there are appropriate courses out there already. One of the first questions I tend to ask is, how old are you? And this is really relevant for breast health because the main risk factors for breast cancer are being female, getting older, previous breast cancer, and a strong family history. This is quite an old slide, but it demonstrates the risk as someone gets older in terms of incidence. And you can see quite a jump between 30 up to 40. But you can tell it's old because it talks about a 1 in 9 risk for lifetime, but actually now we talk about a 1 in 7. Due to this risk of breast cancer, the relevant associations published in 2018 guidelines on imaging in cosmetic surgery. The intention of this imaging is to diagnose or exclude clinically occult breast cancer or lesions of uncertain malignant potential before any operation. And the recommendations were that if they had a normal clinical assessment and no strong family history, women under 40 did not need preoperative imaging. Those 40 or over, we would recommend 2-view mammography of both breasts, as long as they hadn't had a mammogram in the last 12 months. It also recommended an ultrasound in those with dense breasts. What do I mean by dense breasts? Well, this is a grading used on mammography, looking at the percentage of fatty to glandular tissue within the breast. You can see on the left the more fatty breast, which is much easier to identify any worrying features, compared to that very busy, dense breast on the right. There is a significant increased risk of breast cancer with dense breasts. We also will ask about family history. And of course, we're thinking the BRCA gene, and that's why we talk about breast and ovarian. So it is identifying closeness of relatives, number of relatives, any bilateral disease, and any males. Now, if you have any concerns, do ask the patient, because if they have a strong family history, they may have already seen a geneticist and had their test done. But if they haven't, I would get them to do that prior to any surgical intervention. We'll also ask about parity, and how many children they may have had, how many if they breastfed, but more importantly in cosmetic surgery, because this will affect the outcome, is any more planned. So a nice paper there which really tells us what we probably already knew, that patients who have had at least one pregnancy, the vast majority, 85%, notice significant changes to their breast shape. A large number, about a third, having reduction in volume as well. It showed that age, significant weight loss, higher BMI, larger bra cup size, or number of pregnancies, and smoking were significant risk factors for breastosis, which we sort of knew. I do ask about the age of the child because it is about how they're going to manage post-operatively. Obviously, comorbidities, and the ones we really worry about there is smoking. Smoking is a significant risk factor to cosmetic surgery, and its risk should not be underrated. It is important to identify and try and modify the behavior, because we can reduce the risk. And I talk about why it occurs, why there are problems, and I do over exaggerate the risks to those patients. But it's also about showing that they can change things. And a nice little paper on reduction mammoplasty, which showed that if you stopped smoking for 4 weeks prior to surgery, your risk comes down to that of the non-smoker. So very important that we do try and stop patients who are smoking, especially in the higher risk breast cosmetic surgery like reduction or organ-mastose. Diabetes is not a major risk, but it is a risk. I tend to always want a glycosylated hemoglobin beforehand to see how control is, and if they're uncontrolled, I will not do the surgery. So I always want a good level, low level. Again, if it's under control, the risk is minimal, especially in surgery like augmentation, but they do need to know there is risks. It is important to ask about previous breast problems in terms of things like sepsis. Now, lactational sepsis while breastfeeding is extremely common, but non-lactational, which tends to be associated with smoking in premenopausal women, and you can see this is the end stage of it with a mammary duct fistula. Now, this is probably a contraindication to implant surgery because there's a chronic infection behind that nipple. It's also useful to know if they've had any previous diagnoses of breast lumps, fibroadenomas, cysts. The reason for that is you don't want to be surprised when doing an operation and finding a lump that you didn't know about. Breast pain is a very common problem, and after surgery patients are often referred back to you to rule out is the pain related to an implant or scarring. So you will need to ask the right relevant questions. Cyclical breast pain tends to spontaneously resolve in about 30% of women, but can be quite significant. Now, in someone under 35 with no palpable abnormality, they can give a breast pain leaflet, and Breast Cancer Care charity do a very good one. If over 35 and you're not worried it's to do with your surgery, I would refer back to a GP. Now, you will get patients who've had previous breast cancer surgery referred to you. And breast conservation surgery and radiotherapy can leave someone very significantly asymmetrical. Now, what I would recommend highly is don't get tempted to try and correct the treated breast with something like an implant. Radiotherapy is a major problem. And you can see in this woman who they have attempted this, the significant capsular contracture, lack of elasticity, the effect on the breast volume that this woman has on her right side. When you are seeing a patient, do examine them. You know, it's not just about measuring up to see how you're going to change the aesthetics of the breast. Do measure. I also, when I'm examining, talk through the process. Get them, explain why I ask them to raise their arms, what to look out for. I am checking for any problems, but I'm also educating in the patient. And also I'm demonstrating that I care as a holistic approach. But if you do identify things that you're worried about, if you identify a lump, an asymmetrical thickening, dimpling, don't proceed with surgery, just refer to a breast clinic. But there will be things you see that are normal. You may see accessory breast nipples, very common, classically below the breast, or accessory breast tissue. So these quite large examples is seen in about 1 in 30 women and does tend to present after pregnancy. Nipple inversion is a worrying feature to women, but this actually is very normal. It is part of the natural development and involution of the breast, and this is slit retraction. which is completely benign. Nipple discharge is another common symptom, and in the vast majority it is benign. We know that 1 in 5 women, there may be a discharge during compression during mammography, so hence the potential contamination that could occur during augmentation, and why we use a nipple shield to avoid that contamination of the potential of the implant. Do look out for things that could be treated. We've got a nice picture of interrotigo, which you'd want to treat prior to surgery, and hidradenitis suppurativa, so you'd want to make sure also that that's corrected or under control. Look for scars. With the expansion of oncoplastics and the considerate surgical scar placement, the site of the scar can be very distant from where the operation is, and circumareolar scars are the choice, and you could get tunneled. It can be used to tunnel to all areas of the breast, but sometimes it may be used for a total duct excision, which of course we're removing the tissue behind the nipple, which will have implications if you then later want to mobilize that nipple. So look at the scars and think about how they could affect any surgery you have. So when doing that, you are thinking about the blood supply. We know about wearing suspensory ligaments, but in essence, the majority of the blood flow comes from the medial side, and the nerve supply will come from the lateral. I tend to recommend that while doing the operation to examine intraoperatively, because you've got the potential for bimanual palpation. So prior to putting the implant in and checking for hemostasis, do feel. You will be surprised that sometimes you do pick up things, and then report it back. Put it in the op note and tell the patient. If you do a breast reduction, orientate it. Make sure that you know which is superior, medial and lateral, because the number of times we can get a breast reduction that hasn't been orientated will have a very tiny area, and because we don't know where it is, we have to do a mastectomy. Then that could be avoided. What are the sort of questions you're going to get afterwards? Can you have a mammogram? Yes, of course you can have a mammogram after augmentation, but you have a special technique. The Eklund procedure is used. So it's important that patients know that they can have that. It's not quite as accurate as a patient in picking up things as in someone who hasn't had augmentation. Again, with someone who's had breast reduction, it's about making sure they report to the team that they've had that prior to the mammogram. Does augmentation make you at higher risk? No, it doesn't make you at higher risk, probably lower, but we do know that patients who present with breast cancer following augmentation tend to have the same stage and size of tumour. Augmentation doesn't affect breastfeeding, and doesn't seem to have a higher risk of complications. Quick bit on gynecomastia. It is a whole other talk, but remember, gynecomastia is a symptom, not a diagnosis. So if you are planning any cosmetic surgery, ensure that the cause is known, or all important ones have been ruled out and the individual has been investigated. There's some really good guidelines on gynecomastia from the ABS. So in summary, it's a whole patient approach. Remember imaging. Try and reduce the risks by stopping smoking, controlling diabetes. But most importantly, don't be afraid to say no to a case.
Good morning, I'm Jo Skillman. I'd like to talk to you about how to assess breast aesthetics before reconstructive and aesthetic breast surgery. I work as a plastic surgeon in Coventry and also have done oncoplastic training. So my learning objectives for this talk are to help you understand the challenges in assessment of the breast, explain the measurements and some of the tools available, and help you to develop a standardized approach to assessing the breast, including the patient's perspective, oncological assessment, and then the foundation shape of the breast, including the footprint and conus and animation. So perceptions of the ideal breast vary between surgeons and patients, and there's no really objective or quantifiable determinants. The physical appearance of the breast affects both the psychological body image and quality of life. There are no fixed standards of what makes up the beautiful breast, and qualitative aesthetic scales may be quite vague and have poor reliability and concordance. Pat Malucci published this very popular paper looking at 100 consecutive topless models and defined several key features of what makes the perfect breast in this situation. However, it may not be applicable to all women seeking breast aesthetic surgery. There are a number of tools available, including calipers and 3D imaging, some of which help to help your patient see what it will be like with a certain size breast implant. There's also some use of 3D imaging following reconstructive surgery that has been published by Jenny Rusby. I prefer to use a simple tape measure and clinical examination. As part of your assessment, it's important to ask the patient their opinion about their wishes and also about their outcomes. And the BreastQ is a free for clinical use validated questionnaire that looks at all aspects of breast aesthetic surgery. And also there are other questionnaires available for other cosmetic procedures. I would encourage you to use these to help you understand your own outcomes and where you may be able to make improvements. These validated patient-reported questionnaires were used in the National Mastectomy Breast Reconstruction Audit and are also used as part of the FLAP registry. They're repeatable, comparable between patients and groups, and the data collected is recorded into a spreadsheet and a score out of 100 is calculated. So moving on now to breast assessment itself, the patient's perspective, I think, is one of the most important aspects of assessment. Also, oncological assessment is essential even for aesthetic surgery. Then we move on to assess the foundation, footprint, conus, skin envelope, animation, and I've just included a few key classifications. So this lady had an implant reconstruction on the left side. Although it was successful in that she has a breast mound, she felt that it was the wrong shape, the breasts were different heights, and that she experienced pain and discomfort with the reconstruction. The oncological assessment, every patient should have a preoperative history and examination. If this is normal, no imaging is required under the age of 40. However, over the age of 40, ABS recommends a screening mammogram. If the patient has any signs or symptoms that are abnormal or a strong family history, then they should be referred to the specialist breast clinic for assessment prior to embarking on any aesthetic surgery. The first aspect of the examination is the foundation or the chest wall. This can take many forms, and here are some more severe deformities, but often the patient has chest wall asymmetry, which may affect the results of your aesthetic surgery. And although the patient may have not noticed this asymmetry preoperatively, they're very likely to postoperatively. So it's important to mention this to them and discuss it with them before having any plans for treatment. The footprint of the breast tends to be consistent over time. The footprint means where the breast attaches to the chest wall, or the base of the breast, it's sometimes called. And the measurements that I take for this are the width from the medial mammary fold to the lateral mammary fold, the height from the inframammary fold to the breast takeoff. This is the most important thing in breast reconstruction, as if the footprint is correct, then the breast looks much better, even if it's slightly smaller or slightly larger. So this lady had her footprint matched with a Dieppe reconstruction, although I think the Dieppe volume is slightly smaller. This lady was referred to me as a second opinion. She'd had an LD implant reconstruction by another surgeon, and she was very dissatisfied with her result. And the main problem here is her footprint. The left reconstructed breast is wide and the footprint is low compared to the other side. She also didn't want any big reconstruction. So I tried to improve the footprint and put in a slightly smaller implant, and this improved her symmetry. The conus is the three-dimensional shape of the breast and includes the volume, projection, and contour of the breast. And to record this, I measure the nipple to notch, the nipple to IMF, the grade of ptosis and the projection, and also document any missing skin in reconstruction cases particularly. To measure the amount of missing skin, I measure from the mid-clavicular point to the IMF along the breast meridian. I measured the missing skin and felt that there was about 10 centimeters missing in the breast meridian. And her 6 weeks post-op photo shows that I've estimated about right, I think. Animation is the movement of breast with contraction of pectoralis major. And this can occur because the mastectomy skin sticks to the underlying pec major. And as the patient moves, this can tether the skin and the nipple and pull it out of position. Next, the skin envelope. So in cosmetic cases like this, I've recorded that on the left side, she's very short of skin compared to the right. So I've done a mastopexy augmentation on the left and a breast reduction on the right. I have done okay in symmetrizing the nipple position, but I still have a little bit too much skin in the conus on the right breast, which is why you can see more of the inferior breast below the nipple on the right side. I think it's important that you know a few classifications. The first is Raynaud's ptosis classification, which classifies the position of the nipple related to the inframammary crease. And von Heimbo's classification of tuberous breast, which is underdevelopment of the gland, particularly most commonly in the inframedial quadrant. This is a difficult condition to treat. In this case, I've used Kang's technique, where the periareolar skin is undermined and the excess areolar skin is tunneled underneath. And so this stretches out and tucks in the nipple. And then I've done a simple breast augmentation without an expander because she wanted a single stage procedure. The central photos are about 2 weeks post-op. They show a lot of bruising and swelling. And the lower photo is about 4 years post-op, where she has a much better appearance than preoperatively. The final classification is the Simon classification of gynecomastia. In this photo, I've marked his larger breast footprint and the glandular tissue, and this helps you decide whether you need to do any skin excision or simply excision of the gynecomastia. So now I'm going to move on to some clinical cases to apply the things you've learnt about breast assessment. So this lady has had a right therapeutic mammoplasty and she has asymmetry. She feels the left breast is heavy and droopy, although she's happy with the right despite the inferior contour deformity. So I've simply done a mastopexy reduction on this side to improve her symmetry. This lady has had about 7 previous operations for breast asymmetry, and she still feels that the left breast has lack of upper pole fullness and the right is very tight and uncomfortable. The right implant was subpectoral and I've moved it to a submammary position, and removed some of the inferior skin of the left breast to improve the conus. She actually had a silent intracapsular rupture on the right side, which had given her some additional swelling. This is the lady we saw at the beginning of the talk, and for her I replaced about 4 centimeters of skin and lifted the contralateral breast for improved symmetry. You can see now the footprint looks better and the conus or volume looks better with the autologous reconstruction. This lady requested a breast augmentation. I've marked the nipple position, and in order for the implant to be centered where the nipple will be, I've had to lower the inframammary crease because she wanted a slightly larger implant than her natural breast footprint would allow. This lady came to me as a second opinion. She'd had some round implants placed under the muscle by a colleague, and you can see that her breast parenchyma has fallen off the front of the implants. I therefore put in some smaller implants and did a small mastopexy augmentation. This young woman with breast asymmetry has, as you can see, despite good nipple position, she has too much skin on the right side. I've therefore put an implant into the left and reduced the skin envelope on the right for improved symmetry. This poor lady had had a wide local excision followed by radiotherapy and had had a very poor reaction to the radiotherapy treatment. The skin of the right breast was rock hard, extremely painful, and wouldn't have been possible to preserve. I've therefore removed it and performed a delayed DIEP reconstruction and lifted her large ptotic breast on the other side. This lady had very large breasts and wanted breast reduction to be as small as possible, and I have consented her for a free nipple graft because of the length of the pedicles. In fact, I managed to preserve the nipples on a supraremedial pedicle. The final patient is a lady who has very ptotic breasts, grade 3 ptosis. She'd lost about 4 stone in weight and was not keen on implants but wanted some upper pole fullness. So for her, I used her ptotic inferior breast tissue as an auto augmentation, and she hasn't had an implant but has got improved upper pole fullness. So I hope you've enjoyed learning about the challenges in aesthetic breast assessment. You understand the measurement and tools available, and that you have at least got some pointers to develop your own standardized approach. And I believe these should include the patient's perspective first and foremost, an oncological assessment, then assessing the foundation, breast footprint, conus and skin envelope, and any animation. Thanks very much.
I would like to thank Joe Skillman for organising this excellent meeting and for the very kind invitation to speak to you today on breast implant associated anaplastic large cell lymphoma. This talk is an update on the current position in the UK. I have no conflicts to declare. I am a member of PRASIAG, which is the expert advisory group on implants that advises MHRA. This committee is currently chaired by Nigel Mercer. From a historical perspective, it was only as recently as 1997 that the first case of implant-associated ALCL was described by Keach and Creech. A few cases were then subsequently mentioned in the literature, and it was only as recently as 2012 that Gary Brodie made the link to texturing on the surface of implants. Nick Collis reported the first case in the UK in JPRAS in 2014, and the first UK series of 23 cases was reported in EJSO in 2017. We made the point in that article that it was important to obtain informed consent in relation to ALCL prior to inserting a breast implant. The WHO classified implant-associated ALCL in 2017 as a specific disease entity. However, it is a T-cell lymphoma and is a subtype of non-Hodgkin's lymphoma akin to primary cutaneous lymphoma. While it tends to commence on the luminal side of implant capsules, it does appear to present as a spectrum of disease, but it is distinguished by the immunohistochemical marker CD30, and it is ALK negative. The etiology of this condition is unknown. There are numerous speculative causes and associations, the most important of which relates to texturing of implants. And the more aggressive the texturing, the higher the incidence of ALCL appears to be. And this has been repeatedly published in a number of articles. There has been a putative association with the JAK1 and STAT3 somatic mutations and the germline mutation TP53. There has also been a speculative association with aryl hydrocarbons on the silicone particulates, which was presented by Suzanne Turner from Cambridge at the World Congress in Rome in October 2019. The true risk and incidence of ALCL is probably unknown as the number of cases continues to increase, and there is certainly a variation in incidence globally, and this is all probably related to the fact that the denominators are not known. There is quite a variation even within Australia and New Zealand, with practice clustering noted, and there is evidence to suggest that more aggressively textured implants have a higher risk of developing ALCL than those with less aggressive texturing. The current quoted incidence in 2017 in North America was 1 in 30,000, with practice clustering also noted there. However, the UK incidence is currently being quoted at 1 in 20,000. A very low incidence is reported in people of Asian origin, and the risk of death from ALCL is thought to be very low. Because texturing on the surface of implants appears to be so important and dominant in the story of ALCL, there has been an attempt to introduce a classification system of texturing in order to help coordinate reporting around the globe. However, this classification system, which has been proposed, is not universally agreed yet by regulators. Nevertheless, it is a good starting point, and one that most authors now tend to use, which classifies the most aggressively textured surface, such as polyurethane foam, as a type 4, and a smooth or nano-textured type implant as a grade 1. In order to understand the current situation with regards to implant availability in the UK, it is important just to recap briefly on what has happened over the last 3 or 4 years. In December 2018, the CE mark for Allergan BioCell textured implants lapsed, and following the French regulatory hearings in February 2019, Allergan withdrew all BioCell textured implants in Europe. Following the FDA hearings in March 2019, the French regulator then withdrew salt loss textured and polyurethane implants in France. And in July 2019, the FDA issued a Class 1 recall of Allergan BioCell implants. Following this, all BioCell implants were voluntarily withdrawn from the market worldwide by Allergan. In September 2019, the Australian regulator suspended all grade 3 and 4 textured implants and some microtextured devices. Only BioCell textured implants are unavailable in the UK at the present time. All other implants are still available. And no regulator worldwide has recommended routine removal of implants that have been recalled or withdrawn. It is important to understand that breast implant illness is not linked to BIA-ALCL, and this is important when counselling patients. Currently, the MHRA reports 83 confirmed cases as of January 2021 that satisfy the WHO criteria for diagnosis, with 1 confirmed death, 1 confirmed recurrence, and 7 cases demonstrating BRCA1, BRCA2 mutations. However, 22 cases are untested. The problem here is that genetic testing in these patients is not yet commissioned. No clustering has been reported in the UK, and to date, no de novo cases with smooth implants have been reported in the UK. There have been 5 confirmed cases with polyurethane implants, and 58% of the 83 confirmed cases were in cosmetic patients and 32% in reconstruction patients. The current estimated risk in the UK is still quoted as 1 in 20,000, and this is based on implants sold. Needless to say, this does create some difficulty in relation to calculating a true risk, because not all implants that have been sold have been used, and some patients will potentially have been implanted abroad. In terms of reporting in the UK, it is important that any cases that are diagnosed are reported to the MHRA using the yellow card scheme, and the MHRA is supported by the Plastic Reconstructive and Aesthetic Surgery Expert Advisory Group, which is chaired by Nigel Mercer. It is also very important to complete the breast and cosmetic implant registry form, both at the time of a new implantation and also at the time when a diagnosis of ALCL is made. The chairman currently of the BCIR is Lee Martin from the Association of Breast Surgeons. In relation to presentation of the disease, the most common presentation is that of a late seroma more than 1 year after implantation. However, it does need to be understood that more than 90% of late seromas are in fact benign. The vast majority of patients who have presented with ALCL worldwide have had textured implants in situ at the time of diagnosis. Some patients will present with a very aggressive and sudden capsular contracture, and some patients can present with a capsular breast or nodal mass. So-called B symptoms, which are those symptoms associated with lymphomas such as fluctuating temperatures at night, etc., are a rare presentation. It is important to note that up to 5% of cases can be bilateral, and the average time to presentation is approximately 8 years following presentation, although this can be variable. Pap smear analysis of seroma fluid can be unhelpful, as the enlarged abnormal looking cells could be confused with other conditions such as Hodgkin's lymphoma, infectious mononucleosis, or even viral infections. The important diagnostic criteria relate to immunohistochemistry and a single T cell clonal expansion with a greater than 10% diffuse expression of CD30. ALK negativity is not a screening tool, but it is important nevertheless. This slide demonstrates the difference between a seroma containing ALCL positive cells on the left and benign cells on the right, even though they look enlarged on the right side. And this is demonstrated by immunohistochemistry staining for CD30, which shows extensive membrane activity on the left side greater than 10%, and flow cytometry of this sample also demonstrated a single T cell clonal expansion. And on the right side, this is a benign seroma, and although the cells look enlarged, there is very insignificant staining for CD30. Staging of implant-associated ALCL is important for planning treatment. The initial staging classification was that of the Lugano revision of the Ann Arbor staging for liquid lymphoma tumors. However, this is not really considered adequate, and it is now generally accepted that the MD Anderson staging for solid tumors using the TNM system is a better one for breast implant associated ALCL. This slide demonstrates the MD Anderson staging system for ALCL that was published by Mark Clemens and colleagues in 2016. And this has greatly simplified the staging of this disease and has also allowed better comparative reporting between authors globally. Early stage disease is that of 1A as far as 2A, and advanced disease is that of 2B upwards. In order to make a clear and unequivocal diagnosis, it is important to be very suspicious of any patients who present with a sudden painless swelling or an aggressive rapid capsular contracture or a mass in the presence of a breast implant. Any patient presenting like this should be referred to their local breast cancer clinic for full triple assessment. The diagnosis centers around ultrasound guided aspiration of the seroma fluid and, if necessary, a capsular biopsy or a biopsy of a mass. There are now very clear guidelines both from the NCCN and the UK PRASIAG committee on the diagnostic tests and criteria that are used to make this diagnosis. The diagnosis centers around flow cytometry and immunohistochemistry in order to diagnose CD positive 30 ALCL cells. When a patient presents with a mass, then a mammogram, MRI, ultrasound and biopsy with immunohistochemistry will be required and specifically requested as determined by the presentation. The problem arises in those patients who present with recurrent benign seromas. There is no clear agreement on the management of these patients. 90% of late seromas are benign and can arise due to bacterial infections, fungal infections, synovial metaplasia of the capsule following repeat microtrauma, and double capsule formation. However, there are malignant possibilities, including Kaposi sarcoma, and there have been now 6 cases published in the literature of B-cell Epstein-Barr virus positive lymphomas in association with implants, all occurring on the luminal side of the capsule. A further 8 cases are just about to be published, so this adds a whole new dimension to the story of lymphoma and implants. It's also very possible that those patients who present with recurrent seromas may be demonstrating early emergence of ALCL. So for these type of patients who do not settle with simple aspiration over a period of 3 or 4 months, it would be sensible and is now recommended within the UK guidelines that they be referred to a specialist centre that has experience in managing ALCL patients. Management of a patient with ALCL should be within a specialist centre that has a full MDT to include plastic surgeons, breast oncology surgeons, oncologists, hematologists, radiologists, etc. And there are now, again, very clear guidelines on the management of this condition published by both the NCCN and PRASIAG UK guidelines, which were published in JPRAS and EJSO simultaneously at the end of 2020. This is the diagnostic and treatment algorithm for implant-associated ALCL produced by the NCCN in 2019. The UK algorithms were published in JPRAS in 2020 and are very similar. The vast majority of patients present with early disease, and as such there is now good evidence from the literature as to how these patients should be managed. There is general agreement that these patients should be managed by surgery alone, and this has proven to be quite effective. Up to 5% of patients will present with bilateral disease, and in such a situation it is advisable for those patients who have bilateral implants to have bilateral capsulectomies, and it would be advisable to do the unaffected side first in those patients in whom it is assumed that they only have unilateral disease. Treatment involves an en-bloc resection, which means removing the entire capsule with the implant in situ, avoiding any seeding if at all possible, as this will increase the risk of local relapse and recurrence. It is important to achieve clear margins, but mastectomies are unnecessary. For those patients who have very tense and very large seromas, particularly those with cosmetic implants in situ, in whom it may be very difficult to perform a non-block resection through a relatively small incision, consideration should be given to aspirating the seroma on the day of surgery under ultrasound guidance to dryness before proceeding with surgery, but being careful to avoid seeding. Consideration obviously has to be given to your access incisions, and consideration should be given to reconstruction or implant replacement. There is no universal agreement on this, but there isn't really any reason why a patient could not proceed to an autologous tissue reconstruction to replace an implant that has been used for a reconstruction, or to replace an implant in a cosmetic patient. But if you are considering doing this, the general feeling is that replacing with a smooth device would be advisable. In terms of follow-up of these patients, 2-year surveillance appears to be adequate. This is entirely clinical, done 6 monthly. Imaging such as CT or PET surveillance post-operatively appears now to be unhelpful, and at 2 years patients can then be discharged. Most recurrences and relapses appear to happen within the first 2 years. In terms of advanced disease, there is no universally agreed algorithm on how to manage these patients. But generally speaking, for those patients with locally advanced disease, surgery is still the mainstay of treatment, clear margins being absolutely essential in order to try and reduce the risk of local recurrence and relapse. Radical mastectomy is unnecessary, and there is no place for sentinel node biopsy in ALCL or nodal clearance. So for those patients with involved or suspicious nodes, it's only those nodes that are thought to be involved should be removed. In terms of adjuvant treatment for these patients, there is some evidence to show that replacing the vincristine element of CHOP chemotherapy with brentuximab vedotin can be helpful in improving the overall survival and disease relapse survival in these patients. And this was demonstrated in the Echelon 2 phase 3 randomized controlled trial. Brentuximab is also licensed in the UK as a single agent treatment for those patients with ALCL who present with relapse or refractory disease. For patients with systemic disease, anthracycline-based regimens may be helpful, and brentuximab alone may also be helpful, as already mentioned. Stem cell rescue has been used in some patients, and radiation treatment may be helpful for some patients in certain circumstances. Again, all of these decisions around adjuvant treatment for these patients need to be made at an MDT in conjunction with oncology colleagues. This final slide demonstrates some of the major outcome studies that have been performed on patients who have presented with breast implant ALCL. The first study that was published was by Roberto Miranda from the MD Anderson on 60 patients, and they showed that there was a 93% 5-year survival for those patients who presented without a mass, and a 72% 5-year survival for those who presented with a mass. They used the Ann Arbor staging system for that particular study. The second study, published by Mark Clements and Roberto Miranda, again from the MD Anderson Center in 2016, followed up 87 patients who were diagnosed and treated with breast implant associated ALCL, and the event-free survival and overall survival, Kaplan-Meier survival curves, are shown on the left of the screen. And they demonstrated, first of all, that there is a good prognosis overall for most of these patients. But what is really interesting is that for patients who have incomplete surgery, there is no doubt that these are limited surgery. There is no doubt that these patients do badly when compared to those patients who have complete surgery. In other words, an unblocked resection with clear margins and no evidence of seeding. Additional treatments such as chemotherapy and radiation therapy can be helpful, but really the mainstay of treatment, as you can see from these survival curves, is surgery. When we also look at these 87 patients stage for stage based on the TNM system rather than the Ann Arbor staging system, we can see that those patients who present with stage 1 disease do much better in terms of event-free survival and overall survival compared to patients who present with stage 2 or stage 3 disease. And Collins explored this further in a paper published in PRS in 2019, when he compared 39 patients who presented with advanced disease to 65 patients who presented with early disease. And they were able to show that the patients who presented with advanced disease obviously did not do as well as those patients who presented with early disease. But interestingly, what they found was that the patients who presented with late disease had a long presentation pathway. In other words, there was difficulty in making the diagnosis on these patients. And also these patients had a much lower rate of complete surgery. So it is clearly important for these patients that the diagnosis is made as expeditiously as possible, and that the most important element of managing these patients is to diagnose them early and treat them with complete surgery. I would like to thank you for taking the time to listen to this presentation, and I'll be happy to take any questions.
In this section, we will discuss what aspects of breast aesthetic surgery are important to know for the FRCS PLAST exam. Make sure you have a good grasp of the basic anatomy of the breast and how this is relevant in planning surgical procedures. The basic anatomy is the same in men and women, but with more prominent glandular development in women after puberty. The breasts lie on the anterior thoracic wall from the 2nd to 6th ribs and superficial to the pectoralis major and serratus anterior muscles. Blood supply is via perforating vessels from the internal mammary medially and laterally from the lateral thoracic and thoracodorsal arteries. Intercostal perforators come in inferiorly. Nerve supply is from the 4th to 6th intercostal nerves. Lymph drainage is mostly to the axillary lymph nodes, but 20% goes to the parasternal nodes and about 5% to the posterior intercostal nodes. For any patient requiring aesthetic surgery, the first thing to establish is what concerns them about the thing they want to change. You also need to ask what they hope to achieve from their surgery. You may look at them and have a view on what needs doing, but it is the patient's hopes and expectations that need to be addressed in order to get a good outcome. If their hopes are unrealistic, you need to explain this to them. Their general body habitus is important and is informed by establishing their BMI. For patients requesting breast surgery, it is also important to establish their current breast size, and so ask what size bra they wear. In their past medical history, the targeted history needs to include pregnancy, breastfeeding, and any previous surgery. It is also important to know if they intend to have children in the future. As with all clinical examinations, begin by looking to get a general impression of size, symmetry, and ptosis. Also look for scars and signs of any previous surgery or radiotherapy. Check for any chest wall anomalies. In a clinical setting, this is a good time to ask permission to record what you see with clinical photos. Certain measurements are valuable and should be recorded. The most useful are listed here. Some would also add to this list the distance from the superior margin of the breast to the nipple. It is important to establish their current breast size. Many women wear ill-fitting bras, and so you need to know how to measure this yourself. Remember, the bra number is a measurement of the chest wall circumference. The cup size, which is denoted by a letter, is a measurement of the breast volume. However, you also need to understand that the letter is a relative measurement, not an absolute one, so that, for example, a C cup for a 34 chest is smaller than a C cup for a 40 chest. Making an assessment of bra size yourself will give you an accurate basis from which to advise your patient and to plan your surgery. Two measurements are necessary. Firstly, around the chest wall at the level of the IMF, and secondly, around the chest at the point of maximum projection. This is best done with the patient's breast supported in a bra. A calculation is then made as shown here. So let us consider breast augmentation. The aim is to increase the size of the breasts, and this is most commonly achieved by the use of silicone implants. You need to choose the size, shape, surface, and filling of the implant you're going to use. You also need to decide on what pocket you will use and how you will access it. Most commonly, the access is via an incision in the IMF. These pictures show the results of a standard breast augmentation with a round silicone implant in a subglandular plane via an incision in the IMF. The first picture is pre-op. Note the slight asymmetry of volume and nipple height. The second picture is at 1 week post-op. Note the swelling and tightness of the skin. Finally, the third picture is the result, and the slight asymmetry of the nipple height persists. A standard breast augmentation does not change the nipple height and does not alter the upper border of the breast. You should be aware of the most common and most important complications. These pictures show implants that have been explanted with total capsulectomies. The left implant was ruptured and had a thickened capsule. The tissue was sent to histology to exclude ALCL as there was a suspicious lump. This was marked with silk suture and in the end proved to be benign. Be aware of the current view on breast implant illness. BII covers a myriad of symptoms and remains poorly understood. However, it is important to advise your patient about it and consent for the possibility of it. Breast reduction remains one of the most requested breast operations. The procedure is generally requested for relief of the symptoms that are consequences of heavy breasts. However, a good aesthetic outcome is also important. The aim of the operation is to reduce the volume of the breasts by removal of skin, fat, and glandular tissue. It also has the intention of uplifting and improving overall shape and symmetry. You need to be aware of the different scar patterns that can be used to achieve this, and associated with that are the different vascular pedicles that are used to maintain the blood supply to the NAC as it is lifted up. As with all operations, you need to be able to describe to your patient the consequences of the surgery and the potential complications. The operation of mastopexy has a similar range of techniques as breast reduction surgery. The intention is still to lift and reshape the breast, but with mastopexy, the volume is maintained. The Raynaud classification for assessing the degree of breastosis is the most commonly used, and it is simple to remember. The NAC is lifted by mastopexy, something that cannot be achieved by implants alone. The lateral views shown here are of the result of a mastopexy and demonstrate the repositioning of the NAC. The volume of the breast remains the same. For patients who desire uplift as well as an increase in size, mastopexy may be combined with breast implants, but there is a much greater risk of significant complications, and so the option of doing this in 2 stages should be discussed. Now let us consider gynecomastia. You should have a knowledge of the main causes and the possibility of non-surgical management. The overdevelopment of the male breast occurs due to an imbalance of active androgens to estrogens and is therefore seen for different reasons in newborns, adolescents, and in older age. The pictures here show the result of a staged surgery combining liposuction and excision of glandular tissue via periareolar incisions. The most commonly used classification for gynecomastia is shown here. It is useful as it informs the type of surgery that might be considered. Liposuction is useful to remove fatty tissue with minimal scarring. It may need to be combined with the excision of a glandular disc via a periareolar incision. When skin reduction is required, more extensive scars may be necessary, or even reposition of the NAC by grafting. For the FRCS plastic exam, you will need a basic understanding of congenital breast defects, and so we will consider some of these now. The incidence of Poland syndrome is 1 in 30,000, but it is commonly seen in exams. Poland syndrome may be associated with significant anomalies of the breast and chest wall, as well as the hand. Sometimes these are very subtle and are only diagnosed when the patient is considering breast surgery for other reasons. Here are examples of this syndrome. The first picture shows a girl with left-sided Poland's treated with a small implant. The second picture shows untreated right-sided Poland's with lack of breast development and the absence of pectoral muscles. When presented with a patient who may have Poland's, always examine the chest wall and the hands as well as the breasts. Tuberous breast deformity is another condition that you will need to be able to discuss. It comes with a wide range of severity, and the Heinberg classification here is therefore useful to remember and to use as a guide to treatment. Surgery can be as simple as the use of implants, but may be more complex with the use of glandular flaps to augment the deficient lower pole. These 4 pictures are clinical examples of the 4 levels of severity described by Heinberg, A to D here representing types 1 to 4 respectively. Note the hypoplasia of the lower medial pole in the first picture, followed by the second picture with medial and lateral deficiency, but both having sufficient skin in the subareolar region. The third picture shows medial and lateral deficiency with insufficient skin in the subareolar region. And finally, the last picture shows severe breast constriction and minimal breast tissue. Here is an example of a type 2 deformity treated successfully with breast implants in the subglandular plane. The first picture is pre-op and the second one a week post-op, with post-op swelling still present. The final result is shown in the third picture. This type 3 deformity was corrected with a combination of periolar mastopexy, parenchymal flaps and fat transfer. Unfortunately, weight loss a few years later led to a less good result. When correcting any breast asymmetry, it must be remembered that asymmetry may recur as time goes on. In this case, having achieved symmetry of volume, nipple position symmetry became less good with time. In a patient who prefers not to have breast implants, fat transfer is a good option, although it may require more than one operation. Asymmetry combined with a tuberous deformity can be challenging, as shown with this patient, who initially had a left augmentation and right breast reduction, but subsequently needed bilateral mastopexies. Asymmetry combined with a chest wall deformity also presents further complexity. This patient required a sternal implant for pectus excavatum and then differential breast augmentation. Accessory breast tissue in the axilla is often present, but not always of concern to the patient. In these pictures, you see on the left a woman who has had a breast augmentation, and on the right, a woman who has had a breast reduction. Neither woman was concerned about their axillary breast tissue. This woman was concerned about the swelling in her right axilla and wished to have it removed, and in order to gain symmetry, this was done. Histology confirmed the tissue to be benign breast tissue. So in conclusion, for the exam, you need to have a basic understanding of breast anatomy. Be confident about how to take a history and do a clinical examination. Have an awareness of how to assess breast size, as in calculating their bra size. Note how to select an appropriate breast implant and be able to discuss ALCL and breast implant illness. Understand different approaches to breast reduction. Know classifications of common conditions and how they relate to the treatment options. And finally, I wish you the best of luck.
Thank you so much to all the speakers who gave some fantastic talks in this morning's session. We are going to continue questions for just under 20 minutes and then give everyone a break until 11:15 when we're going to start the breakout sessions. So some people have kindly asked questions already. And the first question on the live chat is to Stephen from Will Holmes. So I'd ask him to answer that question, which is, how do you define a strong family history, which would make you more likely to refer the patient to the breast clinic before aesthetic surgery?
Thanks, Joe. Thanks for this morning. Family history, obviously you'll be asking, the most common ones are breast and ovarian that we'd ask about. So it's going to be the number of relatives and how close they are to you. So if you've got a first degree relative under the age of 40, I think that would indicate a referral. Now, we don't you'd not seen in a breast clinic. What you would be doing is suggesting either going to your GP, or there are forms online where they fill out and send to a genetics unit. So if you have anyone you're worried about, actually that's the simple option, is just to have the form available and know the process. Because in the West Midlands, we'd send up to the genetics unit. They look at the form and then give an idea of where that person should be. And that may be absolutely nothing, may be routine, regular mammography from the age of 40. In young women, it might even be MRI. So male breast cancer, bilateral, young ovarian cancer under 60, in first or second degrees, would be worth putting in a form for that. Hope that helps. There are specific, I could go through the whole list, but I don't think that's going to help. Most people will realize, and those people who've got really strong family histories normally have already been seen and discussed with their general practitioner and then been referred. So that's why it's important to ask, because if they have been, they've probably been tested.
Great, thank you very much. So the next question from Noor is about smoking. Before considering aesthetic surgery, do any of the panel have a view on how long a period the patient should be stopping smoking for before surgery, whether vaping is okay, and do you test them to check that they're telling the truth? Ruth, I think I always remember you were quite definitive about your smoking preferences, but tell me, is that still the case?
Yeah, thanks, Joe. So we all know that smoking can have a negative outcome on the consequence of any surgery, and especially so in some of the aesthetic procedures and implants and everything. So, my feeling is that they should be no longer addicted to nicotine by the time they come to surgeries. And so, you know, we used to say 3 months. And on the NHS, because we became quite particular about this, we did start testing, and we wondered whether that was a good thing to do or not, or whether it was necessary to do or not. And so our first trial of the testing, when they came to pre-admission, we didn't tell them we were testing, we didn't say, and we had no intention of stopping the surgery going ahead if, depending on the results, because it was a trial run. But what we found out with that was that 30% of people lied about stopping smoking. So then we did it. Then we did continue to test and told people that they must stop. That was on the NHS. I don't have access to testing with my private patients, but I do, you know, severely encourage them not to smoke and explain that if they do carry on, they are likely to get more complications.
Thank you. Do any of the other faculty have a view? Joe O'Donoghue, do you stop people smoking before you'll do surgery for them, or try to? Oh, I don't know if he can hear.
If you can't hear, Joe, when my anaesthetist tells me that they need to
Yeah,
stop.
I do ask them to do so.
Sorry.
Like Ruth, we don't test either on the NHS or privately.
Thank you.
Can you hear me?
Yes, I can now. Do you how long a period do you ask them to stop for, and would you be happy with them vaping? I'm not sure if you can hear me.
For me personally, I like them to stop for 3 months, even if they're having a breast augmentation. And I would ask, and I also include patients in that who vape, even
Thank you. Dean or Stephen, do you have any views about the smoking side of things?
Yeah,
I think it's really difficult. I think trying to get someone, you know, it's an addiction, and asking them to stop smoking, it is, when in cosmetic cases, they are investing themselves. So they tend to be more proactive than actually an NHS, I've found, and they will stop, and we tend to say for at least 6 weeks. Vaping I find quite tricky because I don't, you know, you're telling people not to have any nicotine, but I don't mind as long as if them continuing if it's nicotine free. But a lot will say they have and won't, and we know that because you see them smoking outside afterwards. So it's, but I'm less concerned on the small, straightforward, lower risk surgery such as augmentation compared to an augmasto is a definite no. You wouldn't ever want to do that.
Great. Dean?
Can you hear me, Joe?
Yes.
Okay, cool. Yeah, normally I would say 6 weeks, mainly because it takes that long for the lungs to recover after stopping smoking. Because when you stop smoking, the lungs recover and their chest gets worse. The anaesthetist gets really angry. So if they're going to stop smoking, I usually say 6 weeks. And like Stephen, I would tell them that they're not allowed to use nicotine vapes as well.
Great, thank you. So please, could any delegates who have any other questions add them to the live Q&A just before we finish, if there's anything else that any of you would like to ask. Our next question, also from Noor, is there a point, a measurable upper limit, where you would consider doing a free nipple graft rather than a pedicled nipple breast reduction? Stephen, perhaps start with you. Is there a fixed point where you won't do a pedicle?
No, it depends on the individual. And I think we can get very fixed on numbers and where nipples should be. It's all about the shape and the health and the comorbidities of that individual. You know, you have to be safe, so you don't want to be ridiculous. But if you're starting out, I would be quite conservative. But now you'll sometimes do a pedicled mobilization using the nipple, and then if I'm at all concerned, convert it, and that would have been talked about in the consent process before. But I always feel it's better to try and keep a nipple on a pedicle because they don't lose their color, sensation, all of these sort of things. Well, they don't usually have sensation, but yeah, they feel more natural.
Ruth, do you have a upper limit?
Right, I'm going to put my neck on the line here. I have never done a nipple graft. I don't operation. I always aim to do breast reduction surgery so that the nipple does stay sensate and as well as vascularized, and it seems to work. You know, I think it's possible. I think if you're careful, you can do that. And I just don't like nipple graft results really. So I've never done it, and touch wood, that's worked for me.
And how do you generally do a supremedial pedicle or a based on Weringer's septum as described by Hamdi, or how do you maintain your sensation and vascularity?
It does depend a lot on the shape and size of the breast that I'm operating on. So sometimes a supremedial pedicle, more for the smaller reductions, interestingly, and for larger reductions, I do maintain that septum and use what I would call a sort of combination of an inferior pedicle with a central mound. So you're basically keeping every little bit of vascularity coming in to the tissue that you keep, and wrap the skin and subcutaneous tissue around it. And again, you know, that seems to work. Even with a massive reduction, that seems to work.
Great, thank you. Joe, I think we've got a slight delay, but hopefully you can hear me. do you have an upper limit to your breast reduction pedicle?
Thanks, Joe. We do have a slight delay. Sorry about this. No, I don't do planned free nipple grafts. I've never done one. Like Ruth, I have done 2 unplanned free nipple grafts for patients whose nipples were blue at the end of the procedure, and I couldn't get them to settle down.
Okay, great. Thank you. Dean, do you have an upper limit?
Yeah, I mean, Joe, I'm a simple do free nipple grafts, and the reason I do them is if I think sometimes you get very large ladies who want to be very small, and I think that's very difficult to do with a pedicle. And I think with appropriate counselling, I tend to get a better shape of a big reduction with using a free nipple graft. So that's the main reason that I would tend to do it.
Great, thank you. Well, unless anybody else wants to say or contribute to anything else, I'd like to thank all the speakers, including Nigel Mercer, who wasn't able to attend this bit of the Q&A. Some really fantastic talks and a great start to the day. Everybody is welcome to go and have a bit of a break. When you come back to the session at 11:15, you need to log on to the timeline, and that will have allocated the delegates to a group. And there we're going to have an interactive session. There are 5 interactive sessions in total, and these are supposed to be a more interactive, discussive type of session rather than a didactic session. And each session will be repeated 5 times with lunch after the 3rd session. So I look forward to seeing you all at 11:15, and thank you to all the faculty for your excellent contributions.